Chapter 12, Aseptic Technique and Sterile Compounding. We'll skip over the terms and definitions because we'll cover them in the chapter. And there's quite a few for this chapter. Proper preparation of parenteral medications is one of the most crucial responsibilities of a pharmacy technician that works in a hospital because these medications enter the bloodstream directly, usually through injection. So basically, we have to make sure that we are using every sterile process available to not contaminate these medications because they're going directly in the bloodstream. If we accidentally give you the wrong dose or the medication is not correct or not sterile, we could introduce you to bacteria in your bloodstream and we could possibly give you the wrong dosage, which if you inject a medication into somebody directly and it's too high of a dose, it's really hard to fix that. If we take a medication by mouth, if it's not the right dose or something happened, you got the wrong medication, we can fix that because it's going to take a while for it to get to your system. So just a little side note. Aseptic technique involves procedures used to eliminate the possibility of the drug becoming contaminated with microbes or other unwanted particles. The pharmacy technician may prepare compounded sterile products in pharmacy settings such as home health services and long-term care facilities. The regulations of United States Pharmacopoeia 797, pharmaceutical compounding sterile preparations are explored, as are policies established by other organizations to monitor compliance in the sterile preparation of compounded products. Wider varieties of parenteral medication are used in the hospital than in any other setting. So we have box 12.1 that has the abbreviations and descriptions of pharmacy stock. Solutions, medications, and supplies may be required when preparing sterile products. The terms used to identify these items often are abbreviated in prescribers' orders and on supply lists. Pharmacy technicians need to understand these terms and abbreviations to interpret orders and fill stock levels in the intravenous room. Box 12.1 lists some of the most common terms and abbreviations for IV supplies. So when you see AMP, that's an ampule. It's a 1 to 50 ml glass container that contains medication. A flexible bag. MDV, which is a multi-dose vial. It holds multiple doses of medication. SDV, it's a single dose vial, holds only one dose of medication or a vial that can go anywhere from 0.5 to 100 ml. D5NS, 5% dextrose and normal saline. D5 1/2 NS, 5% dextrose and 0.45% normal saline. So normal saline is 0.45%, half normal saline is 0.45%, and the full strength is 0.9%. D5W means 5% dextrose and water. And like D10W is 10% dextrose and water. We have diluent, lactated ringer solution, normal saline that has a concentration of 0.9% sodium chloride, 1/2 normal saline, 0.45%, which we've already talked about. And then we have routes of administration, and these are really important for the hospital pharmacy technician. Intradermal injections, ID. IM, intramuscular into the muscle. IT, intrathecal into a sheath, such as the lumbar sheath located at the base of the spine. IV, intravenous into the vein. IV, push into the vein directly from a syringe. Subcut, subcutaneously under the skin. Miscellaneous terms for parenteral medications, drip or infusion, an IV bag that is infused over a specific amount of time but is not given IV push. NPO means nothing by mouth. On call means the physician wants the dose to be ready when he or she decides to give the medication. Most anesthesiologists order on call preoperative medications. Post-op is medication to be given after surgery, like pain control or antiemetics, like that's going to stop you from throwing up. Pre-op drugs, medication to be given before surgery, like sedatives or antiemetics. PRN, you should hopefully know by now that it means to be given as needed, and Q as quantity sufficient. When working in a hospital setting, all employees must comply with the standard precautions, universal precautions. To prevent the dissemination of highly contagious diseases, hospitals usually require an employee to receive both tuberculosis testing and an immunization against influenza annually. And you can probably add in COVID. I don't know that places are mandating it. They were. I don't know what the rules are, but probably add that in. This book is a little bit older. Based on the anticipated exposure to potentially infectious substances, each area in the hospital has specific infection control guidelines. Employees are expected to meet these requirements, including hand washing, orderliness, and cleanliness. The pharmacy does not supply blood or blood products. However, pharmacy personnel must participate in training sessions on bloodborne pathogens so that they not only understand various aspects of contamination, but also are aware of ways to prevent exposure and transmission of infections. For example, training includes the interpretation of room signs that indicate patient isolation, droplet or contact isolation, and the precautions and procedures that should be followed if access to these rooms is necessary. Other hospital-wide standards, employees are not to use patient restrooms. They should use only employee restrooms. Medication refrigerators and freezers may only hold medication. They should not be used to store food or drink. Eating is prohibited in any drug preparation or patient care area. All injectable drugs and other compounded sterile products must be made in a clean room under laminar flow hoods. All flow hoods are recertified every 6 months by an independent contractor or anytime the hood is moved. Excuse me. Routine maintenance of hoods includes cleaning all work surfaces and pre-filters. Records of all inspections are to be kept on file in the pharmacy department. Different types of equipment are available for IV preparation, depending on the amount or volumes to be prepared. For instance, many different types of automated pumps automatically fill IV bags and other sterile containers. These pumps range in complexity and cost. For example, if large multi-additive automated machines are rented by the pharmacy, only the tubing required for the specific pump needs to be purchased. Small pumps, such as Baxa's repeater pump, are used to administer smaller reconstitution volumes into single dose vials or larger volumes into multi-dose vials. In addition, a wide variety of supplies used in the clean room must be kept in stock for daily use. For this reason, the technician must inventory these supplies and reorder stock daily, anticipating the stock needed for the next day. Commonly used intravenous room supplies. So we have 70% isopropyl alcohol. It's an antiseptic for cleaning the hood and many other things. Ampule breaker is a device you can put on one end to break the ampule. Filter needles. It prevents glass from entering the final solution when drawing from an ampule. Filter straws used for withdrawing medications from ampules. Filters used for specific medication to trap particles from entering IV fluids. Forceps, instruments that lock, used to obstruct tubing while transferring medication. Male and female adapters, universal size, fits on a syringe on each end for mixing two contents. Mini spikes, large bore spike that is pushed into a vial with the syringe attachment at the other end. Sterile 70% alcohol pads. Syringe caps, a sterile cap used to prevent contamination of syringes during transportation out of pharmacy. Syringe needles, most common bore sizes used in pharmacy are 16 to 20 gauge. Syringes, instrument that holds 0.5 to 60 ml for administration of medications. Transfer needles, a needle on both ends used to transfer a vial to a bottle. tubing for pumps. Tubing is specific to the manufacturer's machine, and tubing transfer sets. Blood transfer sets used to transfer the contents of large containers into empty containers. Syringes used in the pharmacy are available in 8 basic sizes. So 0.5, 1, 3, 5, 10, 20, 30, and 60 ml. As the size of the syringe increases, the accuracy decreases. So if we measure something that's 0.5 ml, it's going to be more accurate if we measure it in the 0.5 ml versus like a 60 ml syringe or whatever. Syringe tips are available in 2 types. A tension type syringe has a 1 ml volume. In this case, the needle is attached by friction only. This type of syringe can be used for withdrawing insulin and other medications that require volumes equal to or less than 1 ml. However, these tension type tips cannot be used when preparing doses of chemotherapeutic drugs because of the risk of the needle detaching from the syringe and causing a spill or possible needle stick to the technician. On all other sizes of syringes, the needle is held in place by a locking mechanism commonly referred to as a Luer lock. This ensures a safe seal for withdrawal of the medication. So kind of see the anatomy of a syringe and the anatomy of the needles. Another type of syringe is a Tubex or Carpuject. These cartridge systems can hold a variety of medications and are available in volumes from 0.5 ml up to 3 ml. The bottom of the cartridge is screwed into the system's syringe holder. The syringe cartridge holders for these systems are reusable and normally are dispensed to the nursing units by the pharmacy on request. The Tubex or Carpuject cartridge is discarded after use. If desired, the holders may be autoclaved for sterility. Needles are made of aluminum or stainless steel and are available in many different gauge sizes and lengths. Higher gauge needles like 20 to 25 gauge are used by nurses to administer injections. The nurse determines which gauge and needle length to use according to the injection site. In the pharmacy, needles are used to draw solutions into a syringe, not to administer to patients. A limited number of needle gauges are available in the pharmacy, and the lower gauge needles make drawing medications easier. The most common needle sizes used for preparing IV medications are 19, 18, and 16 gauge, which are used to draw solutions from vials or other containers. The bore size refers to the circumference of the needle opening. As this increases, so does the probability of coring or cutting out a piece of rubber from the vial's rubber stopper. When a vial is cored, a chunk of rubber is dislodged and may fall into the vial. To avoid coring, the bevel edge should face upward. If coring does occur, a filter needle must be used to prevent the piece of cored rubber from entering the parenteral solution. No part of a needle below the hub should be touched. The point and shaft must remain sterile. So just a tech note, you should not wipe needles with sterile alcohol. If you touch the needle with alcohol or something unintended, like something outside of the vial, the needle must be discarded and replaced with a new one. Typical filter sizes are 10, 5, 1, and 0.45 micrometer. The smallest filter is 0.22 micrometer, which removes all unwanted particles from the solution. If use of a filter needle is necessary, the technician must follow the manufacturer's guidelines regarding filter needles suggested for the specific medication. Some medications should never be filtered because filtering would remove the active drug from the solution. Filter needles are for single direction use only and cannot be used to withdraw and inject a solution. Another type of filter is the filter straw. The straw-like needle can withdraw a larger amount of solution quickly, sifting it through a filter in the hub of the needle. The filter straw often is used to remove any fine particles of glass from an ampule. The filter straw must be replaced with a normal needle before the medication is pushed into the container. So here's all the different filters. Everything we just talked about up there. All the items stored in the IV room must be kept in stock above their minimum levels at all time. Current USP standards require that a minimum number of supplies be kept in the clean room. Only items that will be used immediately for direct compounding should be in the clean room. Supply items must be wiped down with an appropriate cleaning solution before they are brought into the clean room. Before and after each shift, the IV technician is responsible for reordering and restocking the clean room for the next shift. Some of those supplies can come from central supply area of the hospital and arrive by the next shift. However, some of them are going to come directly from the pharmacy wholesaler and can take 2 days to a week. Many IV antibiotics are available in pre-made bulk packs. For example, 12 or 24 packs are frozen in boxes. Although these are convenient, they are more expensive than those prepared by technicians. Most of the time, technicians prepare the IVs needed throughout the week. Certain IV medications can be frozen in either IV solution or syringes, but each bag must be marked with the date of the reconstitution, the beyond use date, the concentration strength, and the preparer's initials. Because prepared solutions differ in their volumes and or concentrations, understanding the routes of administration are important. The route of administration of each type of medication must be stated on the label. Many different types of containers are used to deliver medication. Advanced technology includes smart pumps, which contain databases of drug information, concentration, and dosing units and limits. Flexible bags and bottles are the two main types of piggyback containers. The sizes and types of piggyback containers and solutions range from 50 to 250 ml. So here's a figure 12.7, shows you the gravity pump system, intravenous piggyback setup. Large volume drips include ViaFlex bags and 500 ml in 1, 2, and 3 liter volumes. Volumes greater than 1 liter are often reserved for use with parenteral nutritional formulas. Parenteral nutrition is a combination of essential nutrients that is administered through a drip system for several hours, up to 24 hours. Small volume piggyback containers and solutions are available in 50, 100, 150, and 250 ml volumes. Small volume drips can be piggybacked onto large volume drips. Patients who require analgesics after major surgery and individuals who are in hospice normally have their medications prepared in the pharmacy. In the hospital setting, nursing stations stock various strengths of controlled substances intended to relieve extreme pain. Depending on the physician's order, the nurse can prepare IM or IV push doses from the controlled substances cabinet. When a patient is in severe pain, physicians often order analgesic medications such as morphine or fentanyl on a schedule, like every 6 to 8 hours. When the strength of analgesic is given in larger doses to patients who have no history of opioid use, the initial effects of the medication can be extreme, causing side effects such as nausea, vomiting, and in some cases, difficulty breathing. Toward the end of the 6 or 8 hours, some patients are once again experiencing pain and waiting for the next dose to be administered. To provide a more constant degree of comfort and to limit unwanted side effects, some patients may be given either an implantable port or catheter system attached to a portable electronic pump system, which administers a steady flow of analgesics that controls the patient's pain more effectively. These pumps are used to dispense controlled substances at a specific rate of infusion. Patient-controlled analgesia is a method of administration that allows the patient to control the rate at which the drug is delivered for the relief of pain. The PCA pump holds a syringe of pain medication that is attached to the IV line and regulated by a computerized device that automatically dispenses the medication. The pump may be programmed to deliver a small, constant dose of pain medicine, and the patient has the option of receiving additional doses if necessary. This is done by depressing a button attached to a line on the machine. The boluses are preset for amount and frequency. Even if the patient presses the button many times, he or she only receives the predetermined amount of drugs. And here's just more about patient-controlled analgesia syringe systems. Cassette pumps are another type of PCA system that can be used at home. The program pumps work similarly to the syringe pumps in that they are preset for dosage administration. Additional boluses may be programmed into the pump per the physician's order and cannot be altered by the patient. A bolus is a predetermined amount of drug that can be administered by the patient at one time when pain intensifies. The United States Pharmacopoeia is responsible for providing safety guidelines for the preparation of parenteral and other sterile medications. In the 1970s, because of the dramatic increase in non-scomial infections, the National Coordinating Committee on Large Volume Parenterals provided guidelines for the preparation of parenteral medications. A non-scomial infection or healthcare associated infection is an infection that originates in a hospital. In 2004, the USP 797 regulations were written with the intent that they would constitute an enforceable standard. The USP 797 standards must be met in all practice settings where sterile products are compounded. The USP, ASHP, and the Joint Commission outlined a timeline tool for total compliance, realizing that it would take time for pharmacies to implement all the changes mandated. Pharmacies in other areas that prepare compounded sterile preparations must research, create, and document their standard operating procedure for meeting USP 797 regulations. In 2008, the USP 797 regulations were updated effective June 1st, 2008. A number of changes were made, including clarification regarding the use of alternative technologies when preparing a compounded sterile product. A comprehensive list of definitions, including the terms used in this chapter, was provided. The risk categories of CSP were revised, and a new low-risk 12-hour BUD category was added. Table 12.2 shows the environmental cleaning solutions. So we're going to clean the laminar flow hood, biological safety cabinet, compounding aseptic isolator, and compounding aseptic containment isolator at the start of each shift, start of each batch, at least 30 minutes and after spills or when the surface is contaminated. Daily, we're going to clean the counters and work surfaces and the floors. Monthly, we'll do the wall ceilings and storage shelves. The USP has three major sections. One, responsibilities of personnel, the risk levels of classification of compounded sterile products. Two, verification, accuracy, and sterility of compounded sterile preparations. Three, training, individual training, and continued evaluation of personnel with respect to compounded products, including both quality and control of the preparation environment. Other areas under USP 797 include any medication prepared by nurses, physicians, or other practitioners intended for patient use, regardless of the setting. The types of products include diagnostics, nutrients, irrigations, radiopharmaceuticals, and otic and ophthalmic solutions. So 12.3 shows terms and abbreviations used in the pharmacy. So anti-area, an area in which all preparations for IV admixture are gathered, including labels, gowning, and drug materials. The critical site, an area exposed to air or touch, such as a vial or needle or an ampule. First, air, the air from the HEPA filter that passes over materials. This air is contaminant free. And we'll go over the rest of them throughout the remaining parts of the chapter. So USP 797 has identified three risk levels, low, medium, high, which are based on various criteria. Additional requirements include the amount of space between the hood areas and sink and the storage location of products. So you can look at here, we have the low risk, medium risk, and high risk. Risk level 1 encompasses medications and procedures used to prepare compounded sterile products, including sterile medications, needles, and syringes. Sterile technique and a use of International Organization for Standards ISO Class 5 hood. The technique must require only minimal manipulation. These items of clothing are typically referred to as personal protective equipment and must be provided by the facility. The technician must verify all ingredients and instructions and visually inspect the solution after preparation. Each person's knowledge of aseptic technique and proper manipulations must be monitored and verified annually. An annual media fill test must be done for each person compounding products in the hood. Safety measures include proper testing and certification of the hood. Medium risk level 2, it encompasses bulk compounding. This includes multiple IVs prepared for several patients or multiple compounded products to be used for one patient over several days. This includes preparing a hyperalimentation to be used over 1 week. Risk level 3 includes all of the requirements for levels 1 and 2, plus additional guidelines. The types of products that this level encompasses are those that are susceptible to contamination. Because of the preparation of non-sterile products and or delayed sterilization, an example is the preparation of morphine and bupivacaine solution from a bulk powder for use in an intrathecal pump. The requirements for this level include semi-annual certification of aseptic technique. As the length of time a compounded IV is exposed to temperature increases, so does the risk of bacterial growth. In addition, refrigeration temperatures must be monitored at least once daily to ensure constant conditions. So we have the storage risk levels, temperature ranges, and expiration dates for compounded medication. All personnel who prepare parenteral medications are required to be trained and monitored for compliance with techniques on a periodic basis. This includes ensuring that the drug ingredients, containers, labeling, and equipment are correct. Table 12.6 shows the United States Pharmacopoeia 797 air standards based on 0.5 micrometer particle size. Most pharmacies can easily meet the educational and training aspects of USP 797. However, that is not true of the new regulations related to the areas where these products are prepared. According to studies conducted by USP, using a laminar flow hood in an open room is no safer than preparing products on a countertop. This has been one of the most significant changes in pharmacy. As a result of the enormous expense required to create these new areas, many hospitals now contract out to specialized pharmacies to prepare their compounded sterile preparations. Facilities that have been able to meet USP standards must also test the air periodically to ensure that guidelines are met. The terms and definitions used to describe types of environments are listed in box 12.2. So we have all the different stuff that was basically just in the other chart. We have airlock, a space of separation between two different air pressures. Air pressure can be either positive or negative. The anteroom, the space adjacent to the cleaner buffer room. Biological safety cabinet, a hood that should be used for hazardous sterile preparation in the clean room. Cleaner buffer room, space adjacent to the primary engineering control room where sterile preparation takes place. Compounded aseptic containment isolator, another type of class 3 CA1 glove box that exhausts 100% of the air through a high efficiency particulate air filter. A compounding aseptic isolator, a class 3 glove box that can have either negative or positive air pressure. A laminar airflow hood, a hood that should be used for non-hazardous sterile preparation in the clean room. The primary engineering control spacer hood where sterile preparations take place. The anteroom is adjacent to the buffer room or clean room and is sometimes called the gowning and degowning area. The minimum size of air particles allowed in the anteroom is 0.5 micrometers and air pressure is monitoring. All donning of PPE occurs in the anteroom, the clean room, where the technician actually prepares compounded sterile preparations. They must meet stringent requirements for air particulate size. USP 797 also requires specific types of hoods to be used for compounding specific sterile products. Laminar flow hoods that have only positive horizontal airflow may be used to prepare non-hazardous medication, where a negative vertical airflow environment may be used to prepare hazardous drugs per the USP guidelines. A biological safety cabinet is a totally enclosed environment that is available in either positive or negative airflow. These cabinets are known as glove boxes or barrier isolator hoods. All types of hoods have high efficiency particulate air HEPA filters, although the way in which they expel the air differs. The hoods must be verified and certified every 6 months or whenever move to ensure their ability to filter contaminants. Both anterooms and cleanrooms must be within standards. Assessments must be completed annually, and any movement of the equipment requires additional inspection. Okay, talking about the airflow now, we just kind of covered that in the above paragraph. For chemotherapeutic agents, we use a vertical flow hood known as a BSC or a CACI because the direction of the airflow and the specifications of the hood. A vertical flow hood provides negative air pressure, circulating the air through an additional HEPA filter and then through a vent away from the preparer. Isolator hoods, known as glove boxes, are closed systems that use a HEPA filter and a sophisticated venting system. These provide the greatest amount of safety to the preparer because of the containment ability. In a horizontal flow hood, the outside airflow starts in the back of the hood, passes through a special filter, and circulates out towards the opening across the deck or direct work area. The special filter is a HEPA filter that traps all particles larger than 0.2 micrometers. The sides of the hood and items within the hood create a disruption of airflow. For this reason, the technician must work 6 inches from the sides and front of the hood. In addition, movement within the hood should be kept to a minimum to reduce disruption of airflow. The concept is similar for a vertical flow hood, although air cannot be released back into the room. For this reason, vertical hoods have a plexiglass shield that separates the technician from the inside work surface. In a vertical flow hood, such as a BSC or CACI for compounding a hazardous drug, the air enters the HEPA filter vertically, flows down, passing into the HEPA filter and then onto the workspace area. A grid at the front of the tabletop draws in the air and filters it out once again through a HEPA filter before it is released into the workspace area or is vented to the outside, depending on the type of venting system used. Regardless of vertical or horizontal hoof airflow, I think it's supposed to say hood. Regardless of a vertical or horizontal hood airflow, the technician must not block the flow of air while working. The air is considered first air and it must remain free of obstruction to ensure the critical areas are free of microbes. A horizontal flow hood should be turned on at least 30 minutes for use. Every 30 minutes while continuous use when there are spills or when there is suspected contamination. As mentioned, there is also a PEC known as a glove box or barrier isolator. It is becoming the most popular type of hood for sterile preparation. It reduces the risk of contamination caused by accidental mishandling of drugs during compounding and reduces the number of environmental microbial contaminants, thus increasing the sterility of the prepared product. So table 12.7 shows high efficiency particular air filtering system standards. ABSC must be turned on at least 10 minutes before use. Procedure 12.1 shows you how to clean a horizontal laminar airflow hood. So all the steps are in here. If you end up working in a hospital or externing in a hospital, they could have different rules and they're going to teach you their way, but you should at least know a little something about that. And then again, 12.2 is cleaning the vertical airflow hood. And 12.3 is cleaning the biological safety cabinet. All right. When CSPs are prepared, aseptic techniques must be used. Normally, nurses do not have the advantage of using a laminar flow hood. However, they sometimes must prepare products for immediate use, and they still must use strict aseptic technique. Universal precautions are guidelines followed by all healthcare workers when exposure to bodily fluids or blood products is likely. Similarly, aseptic technique is used when both hazardous and non-hazardous products are prepared. Products that have been tested and shown to cause adverse or toxic effects in human are classified as hazardous. Some examples are chemotherapy, radioactive, and various hazardous chemicals. Do not touch your face or glasses with sterile gloves because touch contamination is the common way to introduce microbes to CSPs. A medication that contains any microbes or unwanted debris can cause a dangerous infection or even death when administered to a patient. The steps in aseptic technique begin with hand hygiene, followed by proper donning of gloves and gown, cleaning of the flow hood, and finally preparation of the parenteral medication. Procedure 12.4 shows proper hand hygiene. Again, just a little disclaimer for your facility that you end up working at, or if you're externing at a hospital facility, you might have different procedures. They have their own standard operating procedure and they will go over that, or they should go over that with you. 12.5 shows personal cleansing and garbing order. Again, same disclaimer. They could have a different order. They should pretty much be the same, but they could have a different order. Regardless of the type of hood used, the placement of the hands is one of the most important aspects to consider when preparing sterile medications. The technician should practice some simple yet important techniques that reduce the possibility of contamination and errors when preparing CSPs to avoid compromising first air. When working in a horizontal hood, you must not block the airflow or contaminate a critical site or area at any time. To prevent this, grasp the vial or ampule by the front. Avoid placing the hands or fingers right behind the top of the container. When holding up the vial or ampule, keep the fingers from blocking airflow. This technique takes time to perfect and should be practiced constantly until it becomes second nature. And it just kind of shows you the process. Never recap the used needles. Instead, discard each syringe in a sharps container along with the uncapped needle after use. Syringes cannot be reused when changing from one drug to another. This reduces the chance of drug-to-drug contamination. IV push or intramuscular medications can be prepared by the nurse at the nursing station or at the patient's bedside. However, the pharmacy does prepare some IV push and IM medications. These agents are placed in a syringe and sealed with a syringe cap until it's time to administer the medication. Figure 12.16 shows the proper manipulation of an ampule. So you can grab a gauze and break it with your hand like they did. Or if your facility allows ampule breakers, you could do that. So when a solution is pulled from an ampule, there is no positive or negative pressure because this is an open system. That is, the container is open and able to allow air to enter it, replacing the missing volume of solution. However, it is important to remember to use a filter needle when transferring drug from an ampule because small pieces of the ampule may detach and fall into the solution when the ampule is broken. A filter needle may be used only for one draw, push, or pull. Either it can be replaced by a regular needle before the drug is pushed into a piggy bag, or a regular needle can be used to withdraw the solution, and then a filter needle can be used to push the filtered solution into the piggy bag. Otherwise, the glass trapped in the filter needle is pushed into the final solution. The two types of vials are those intended for immediate use, single dose vials, and those that can be used more than once, multi-dose vials. Reconstituting a medication is the addition of diluent such as sterile water to convert the medication into a solution form from powder. If an antibiotic MDV portion has been used, the following information must be indicated on the vial: the date the vial was opened, the date it expires, the diluent used, the concentration, and the technician's initials. Specialized types of vials, such as the Advantage system, can be placed on a small piggyback solution via an adapter. These are not mixed with the solution until immediately before administration. The pharmacy technician is responsible for proper attachment of the vial to the proper solution, but the nurse is responsible for breaking the adapter seal between the vial and the piggyback and mixing the powdered drug with the solution. Because the medication does not mix with the solution until the seal is broken, the IV can be returned to the pharmacy if it is not used. This greatly reduces the amount of waste medication. The manufacturer's guidelines are determined by which microbe is targeted. Pharmacies have a chart that instructs the person preparing the medication as to the type of amount of diluent needed, the normal dosing times, and expiration dates. Antibiotics also differ in how they should be prepared and how long it takes the powder to dissolve in the diluent. Once the drug has been reconstituted, the solution should be checked for color and clarity. So we have examples of suggested dosing time solutions and appropriate volumes for antibiotics in table 12.8. When a diluent is added to a powder, an equal amount of air must be removed from the vial or positive pressure is created, which causes pressure resistance in the syringe. For example, if you are adding 10 ml of diluent to a powder, push on the syringe until you feel a very slight resistance and then stop and withdraw an equal amount of air from the vial to relieve the positive pressure. Repeat this until all the diluent has been added. To work with negative pressure, first withdraw air from the vial until you feel resistance and then allow the vial to pull diluent out of the syringe. Never let go of a syringe. This type of technique works well because there's a less chance of a spill. Hyperalimentation or parental feeding is a term for large volumes of parental nutrition solutions normally prepared for individuals who cannot orally consume nutrition, so they can't eat. For recent stomach or intestinal surgeries, unconscious, various conditions that may adversely affect the gastrointestinal system. So cancer also, my friend that had pancreatic cancer, she was on a hyperalimentation solution daily for months before she passed away. So it is used for a variety of things. Two main types of hyperalimentation are prepared in the pharmacy: TPN, total parental nutrition, and peripheral parental nutrition. A peripheral parental injection is administered into the veins on the periphery of the body, so arms, hands, or feet, instead of into a central vein or artery. Because of the regulations established by USP 797, many pharmacies contract out their TPN, PPN orders to specialized compounding companies. TPN is administered intravenously via the subclavian vein and superior vena cava because of the higher concentration of nutrients. Patients must have a catheter surgically inserted in for this procedure. PPN is administered via a peripheral vein, either in the back of the hand or in another peripheral area in the upper extremity, and therefore is a less complicated procedure. Regardless of how many milliliters run per hour, the hyperalimentation must be changed at least every 24 hours to ensure the sterility of the solution. A standard rate of infusion is 100 milliliter per hour. Therefore, 2400 ml may be used over the course of one day. Most hyperalimentation preparations are tailor-made for each patient. So this figure 12.19 shows a total parenteral nutrition order form, and they would look at the patient's labs, the doctor would, and dose the medication out based on that. All TPM preparations include dextrose and amino acids. Both ingredients help nourish the body. The metabolism of dextrose provides calories and a quick energy source for the bodies, whereas amino acids are the essential components the body uses to synthesize protein, needed enzymes, and other important molecules. Lipids commonly are added to give the body the fat needed for synthesis of important cell components, such as cell membranes. The rest of the additives are additional electrolytes. These components can be determined daily if the patient is in a hospital. Other medications such as ranitidine, cimetidine, and famotidine, which help patients with stomach problems, also can be added to hyperalimentation. Besides stomach medication, insulin often is given in quantities up to 100 units per bag. Only regular insulin is added to hyperalimentation preparations because it is the only insulin product that may be given intravenously. So regular insulin, the only insulin that can be given intravenously. Table 12.9 shows types of parenteral additives. So we have the abbreviation and the meaning. So these are the electrolytes. So calcium gluconate, potassium acetate, potassium chloride, potassium phosphate, magnesium sulfate, sodium acetate, sodium chloride, and sodium phosphate. Then we have multiple trace elements, multivitamins, insulin, selenium, and zinc. We can add Tagamet, Pepsid, and this says Zantac. Just so you guys know, Zantac has been pulled from the market recently, like the last 2 years or so. So this would not be able to be added. Many different types of medications are prepared in a clean room. Some medications must be protected from light, whereas others must be kept in bottles as previously discussed. So 12.10 shows. Table 12.10 shows additional considerations for the preparation of drugs. Amiodarone can only be mixed in D5W. Ciprofloxacin should be protected from light. Insulin, normal saline or half saline must be placed in glass container. Lorazepam should be protected from light, stable longer in glass than in plastic. And nitroglycerin should be in D5NS or NS and must be placed in a glass container. The final step in preparing parental medications is the application of the label. First, check the label against the medication and the physician's orders to ensure that the right medication is being given to the right patient. Although each pharmacy prepares its own label, all labels require the same minimum information. All labels produced for parental medications must be initialed by the technician who prepares them. A registered pharmacist is responsible for the final label inspection. If the medication is not used, perhaps because of a discontinued order, it is recycled for use with another patient. Once the technician has finished using the hood, he or she should clean all unused materials and discard any unused products. In February 2016, a proposed set of guidelines known as United States Pharmacopoeia, USP 800, was added to deal with hazardous drugs in healthcare settings. Special considerations apply in the preparation of chemotherapeutic agents, both in preparation and administration. Two key changes from USP 797 were addressed. HDs must have separate storage in preparation from non-HDs. USP 800 requires the use of closed system transfer devices because the risks involved in handling chemotherapies, technicians must be thoroughly trained in chemotherapeutic admixture technique to reduce the chances of exposure to hazardous medications. Pharmacy technicians should always follow chemotherapy guidelines and should be trained in proper disposal of hazardous substances. Special chemotherapy gowns and gloves are worn to repel any substance that might spill or drip onto the technician during the compounding process. Double gloves are worn for extra protection. Face and eye shields help the technician avoid contamination of the eyes. Masks are worn to prevent inhalation of any dangerous chemical. When chemotherapeutic agents are compounded, preparation and cleanup must be done slowly and carefully, and the proper documentation should be completed. So here's the BSC staging and the special chemo supplies and equipment. If a spill occurs in the horizontal flow hood, it may be cleaned using a gauze pad and sterile 70% isopropyl alcohol. The gauze can be discarded in a regular trash bin. Both pharmacists and technicians must be able to show competency in compounding. Before compounding is permitted, the pharmacist and technician must complete video and written and practical instructions, followed by a media fill test and a written exam. Training and testing must be repeated annually for low and medium risk levels and semi-annually for the high risk level. For a media fill test, a microbial growth medium solution is substituted for the actual drug to simulate the admixture compounding technique. After the TSB is injected into the compounded sterile product, the final container is incubated at 20 degrees Celsius to 35 degrees Celsius for 14 days and then checked for turbidity. A positive test result confirms the presence of microbial contaminants. Per the United States Pharmacopoeia 797 regulations, a media fill test must be completed at the time of hire. Thereafter, it must be performed at least yearly for low and medium risk compounding levels and twice a year for high risk compounding levels. In addition, there is a glove fingertip sample required. And documentation of results is required by pharmacies to document the evaluation of the person compounding.